My name is Mike Demagall. I'm the Director of Accountable Care for Sabre Healthcare Group. And we're here this week rolling out the PATH program. And PATH stands for Progressive Approach to Home. And it's really sort of where we see things going in healthcare. Give you a quick little background on myself. I've been with Sabre / Multi-Care a little over 19 years now. Started on the floor as a night shift nurse many years ago. Been an administrator and operator the last 13 years. And really the last year and a half rolling out and development of the PATH program. And again, PATH is really where at Sabre we see the future of healthcare going. If you look at healthcare, whether you've been in it 19 years, 5 years, 10, or 20 or more years, and you look at the model of care that's out there, it's really a sick care model of care. It's not a healthcare model. You look at how all providers are paid: hospitals, doctors, managed cares, long-term care, skilled nursing. The sicker the patients are, the more money we make. And while that's the model that's been in place since healthcare's inception, it's really a sick care model. It doesn't promote healthcare. The patient goes into the hospital for CHF, COPD, diabetes, whatever the case may be. The hospital's job at that point is to put those blinders on, treat that condition, and get that patient to the next level of care. Whether that's an assisted living, whether that's in a home, whether that's another skilled nursing facility or a long-term care facility. At no point in time in that sick care model have we ever been worried about prevention. Have we ever taught those patients how to avoid getting diabetes or CHF or COPD, or how they can prevent those exacerbations from happening once they have those conditions? That's what healthcare is about, and that's where you're starting to see the future of healthcare go. You saw CMS come out about 6 years ago now and say that the Medicare trust funds are going broke, but there's no dollars left. And you saw some pretty massive cuts to how they changed healthcare, what they paid providers at the hospitals, doctors, skilled nursing facility levels, but also what the patients and the geriatric population was able to get, when they could see a specialist, when they could get this lab versus that lab, when they could get this medication versus another medication. And while they made all those changes and did that, they also increased their copays, their deductibles, their out-of-pocket costs. And when they did that, nothing changed. They came out very early last year and said the exact same thing. Sorry, but we're still going broke in 18 to 20 years. And it's because we're in that sick care model, where an average CHF patient will go to the hospital almost 8 times a year. It's just unnecessary. We can teach those patients how to avoid that. So it's really about us flipping from that sick care model to a healthcare model. You see CMS and the hospitals are now have some things to help incentivize them. If they can produce low readmission rates, for example, at the hospital, they can earn extra dollars, which that promotes healthcare. There's also penalties in place. Hospitals have what they call never events now. If you're at the hospital and you fall and break a hip, you're at the hospital and you develop a wound, those are called never events. CMS says those never should have occurred, and the hospital can no longer get paid for those. Before, it really didn't matter if you fell and broke a hip. I mean, I'm sure the hospital didn't want that to happen, but if it did, they just got to bill for another surgery and have all that extra care they provide. They can't bill for any of that now. Patient's skin breaks down while they're at the hospital can no longer bill for that. That's called a never event. If a CHF, COPD, pneumonia, or an acute MI patient goes back to the hospital within 30 days of being discharged, they can't get paid for that service. If they have too many of those, they also can receive up to a 4% penalty. Now you think to yourself, 4% on a dollar really isn't that much, it's 4 cents. But we just got done meeting with a hospital in North Carolina that we partner with, and their penalty for this year is going to be $1.1 million. Next year it could be up towards of $1.7 million to that hospital. So it's finally, those incentives and the penalties are starting to change behaviors and move to that healthcare model. Skilled nursing facility, unfortunately nothing's changed on the long-term care side and on the skilled nursing facility side. But for Sabre, we want to make sure we're moving in the right direction, and we're starting to look at healthcare. We're starting to look at, and what does that mean really? It means looking at outcomes of our patients here while they're at the facility, but ultimately those outcomes when those patients go home. And that sick care model, we just wished them good luck and hope they were able to be successful when they go home. In a healthcare model, we got to make sure we're doing everything we can to put them in a place to be successful when they get there. Right now, nationally, 20% of all the patients skilled nursing facilities sent home end up back in the hospital within 30 days. Almost 40% of those patients end up back in the hospital within 90 days. That's 4 out of every 10 of our patients go back to the hospital within 90 days of being here. You guys probably see it. I'm sure there's the Mrs. Smiths of the world that are here that come here for rehab 4, 5, 6 times a year. Our job is to put those patients in a position to be successful when they go home and be able to stay there when they get there. That's what PATH is really designed to do. So we'll go through a few of the components today. review those components, and just feel free to stop me, ask any questions you have, comments, anything like that. And as we go through these today, we'll just touch on really 3 of the 4 main components. And the first one being Sabre University. And this one to me really is the foundation of the program. It didn't do myself any good, it didn't do our owners, Bill or George or Karen or any of your regional operators, Marlene or Jolene, your nurse, really any good for us to sort of pound our fist on the table or send emails or phone calls saying you clinically have to get better, you have to produce better outcomes if we weren't willing to invest in the staff and figure out how we can do that. So we created Sabre University. While I don't know if this has gotten around to you guys yet, it will eventually. In Sabre University, we started with the nursing staff, and we purchased full simulation mannequins for the nurses that will go around every 6 months to each region. And those nurses, and the goal of that will be able to work on with those nurses on how to do a full head-to-toe assessment. The goal will be to do that head-to-toe assessment and teach those nurses how to really identify changes in condition. The better off we can do at identifying those small changes in condition, the better off our patients are going to be, the better outcomes we're going to be able to produce. With that, the nurses are able to listen to all the different heart and lung sounds that you may hear on a patient, being able to then effectively communicate those to the physician or the NP or the PA that's covering for that patient. And while we go through nursing school, we're all supposed to understand and learn what every different heart and lung sound are. You know, I could have told you when I graduated nursing school what an S3 gallop was, how that relates to a CHF patient, but the reality was I never got a chance to hear that on a patient. So it was strictly textbook. This will give the nurses an opportunity to listen to all those different sounds. We can program in, there's probably 38 or 39 different heart and lung sounds that we can program in to help develop that skill set with our nurses. So we'll do that. That'll come around at a minimum of every 6 months, and we'll continue to do that. Additionally with that, we rolled out 2 disease management programs, CHF and pneumonia. And while we initially thought we'd have probably 10 or 12 different diagnoses that we'd go for, and our nurses would be able to be experts at, we really realized quickly that we need to make sure we're focusing on what we can really make a difference for right now. Part of the reason we chose was CHF and pneumonia were several reasons. One, our hospital partners are very interested in making sure that we have a strong CHF and pneumonia program. CHF is penalizing them for readmissions. Hospitals are very concerned with that. Part of the reason is why you're starting to see penalties in the industry itself concerned about that, is you'll see that 1/10 of all the costs in this country come from those 2 diagnoses. There's probably 1,000 diagnoses that the hospitals use on a weekly basis, but 2 of them alone just account for 1/10 of all those costs nationally. And you can see why. Partially there, a study back in 2013 showed that 21% of all CHF patients that were admitted to the hospital were considered avoidable. Pneumonia was 4th on that list at almost 13%. And as we read that study, they really felt that those numbers were double. That CHF, probably 40% of all patients were going in, could have been avoided. Pneumonia, 26%. And as you look at the other ones that round out the top 5, COPD, septicemia, and UTI, well, septicemia and UTI and pneumonia are all infections. We can prevent those things from occurring. Now, when we talk in healthcare, we can't prevent 100% of everything, but we can prevent a good portion of it. So pneumonia, and ultimately we'll roll that into a full pulmonary program, we'll focus on that infection control. What can we do to prevent that pneumonia from occurring, or what they call the hospital-acquired or the healthcare-acquired pneumonia? And there's really 4 basic things we can do here. Can anybody give me one of the #1 things we can do to prevent the spread of infections?
Wash your hands.
Wash your hands. That's the first thing. So there's 4 basic I'm thinking of. Can somebody give me something else? What do you guys think we can do to prevent pneumonia?
Good oral hygiene.
Oral hygiene for one, sure. Even more basic. How about therapy?
Keep people out of bed.
Get people out of bed.
Yeah.
Increase that mobility. If we can do that, we can help prevent that mobility from, or that pneumonia from setting in. So instead of offering them a bedpan, get them up and walk them to the bathroom. Instead of letting them eat in bed, get them up, at least sit them at the bedside, or get them up sitting at the bedside chair. Any of that additional mobility will help. We can't just count on rehab to do that. We've got to do that as a staff as well. What else can we do? How about if I walked around here, I'd probably find them in a bag at the bottom of the closet, coming from the hospital.
Incentive
Barometer, yeah. Everybody seems to know what I'm talking about when I say that. Get those out and get them at the bedside. And that's where, as we talk, mobility, hand washing, use of incentives barometers, this is where it takes the entire community. Incentives barometers isn't something nursing has to do or a physician has to do. Every single one of you, whether you're in therapy, housekeeping, activities, dietary, as you're in and out of those patient rooms, you can encourage those patients to use those incentive barometers and help decrease that pneumonia from developing. Along the same lines, the other fourth one that we're talking about is cough and deep breathe. Again, something every one of you in this room can encourage those patients to do. So that's what pneumonia is focused on, is really the prevention of that. Unfortunately, as patients, we see patients develop pneumonia, and that's typically the number 1 or 2 infections in long-term care, along with urinary tract infections. The problem with pneumonia, or the biggest issue with pneumonia, is 24 to 25% of those patients roughly will pass away after they develop pneumonia in this population. So you can see how we can make a big difference. CHF, we'll focus on CHF, and again, it's really about early detection of CHF as we look at those patients. We have a CHF assessment now that has a heart failure score for the nurses to do. That's what they call a proven medical model. It was developed out of Upper New York. It's being used across the country now, and it really helps those nurses and the physician identify when a patient's seeing that early change of condition with CHF. It really ties those symptoms together. Another thing we'll do with CHF, instead of 3 days a week awaits on admission, we're now going to do them for the first 7 days that those patients are here. A minimum of 3 days a week after that. One of the very first things you'll see as a nurse or a physician or just in general with a CHF patient is a weight gain. So if we can identify a 3-pound weight gain in a 24-hour period, that's pretty indicative that that patient's going into CHF. Before that patient has any shortness of breath, any chest pain, any dependent edema, before the nurse is going to hear anything in the lungs, we're going to see that 3-pound weight gain, and that doctor, we're going to be able to relay that to him or her. They're going to be able to probably order 20 milligrams, maybe 40 milligrams of Lasix, depending on the weight and the patient. And that patient's really never going to feel the effects of going into CHF. That weight will come off. They're going to continue with therapy and probably be able to go home in a good amount and an appropriate length of time, whether that's 15 days, 20 days, 21 days, whatever that case may be. Whereas if we're not doing those weights more frequently, now that patient has an 8-9 pound weight gain in a 2 to 3 day period. Patient's telling you they feel like they got an elephant sitting on their chest, and now we're 911-ing them out to the hospital. They're going to go and have a 2 to 3 day hospital stay, maybe 4. They're not going to get an ounce of rehab when they're there. Maybe they'll get a token rehab assessment so they can come back here and evaluation. But that's about it. They're just not going to get that therapy while they're at the hospital. So they're going to come back here more debilitated than they would have if we would have just caught that in the first place. So that's what we'll focus on there. Again, ultimately that pneumonia program this fall will roll into a full pulmonary program. We've been working with the American Lung Association on that, so we're pretty excited to be rolling something out for you guys pretty soon. In addition to those nursing programs, we're going to continue to try to develop Sabre University. We've got some stuff we're looking at for therapy now, for the nursing assistants, and a few more things for the nurses as well, as we want to continue to develop that. We'll get every employee here as we talk today, and we'll talk about the PATH program. We'll talk a little bit about Interact and those transitions of care, and then all of this will be a part of the orientation as we move forward. I think if we really want to flip from that sick care model to a true health care model, it takes everybody in this room in all departments. So we've got to make sure, too many times I think, whether it's Sabre, Multicare, your Manor Cares, Beverly's of the world, have rolled out programs and maybe they get to administration, maybe they trickle to nursing, but they don't get to everybody. And if we really want to make sure we're moving forward in healthcare, it takes all of your eyes and ears to be a part of the patient's care here. So we'll make sure that we do that with all of our new orientees and new employees as they come on board as well. Second thing we look to do is how do we communicate better in long-term care and on the skilled nursing facility side of things. So for years now, facilities have had what they call utilization review, and years ago, that was a quality meeting. It was about the patient, put the patient there, and discuss what was going on to make sure we're working that patient towards their discharge plan. But really, since '99 in PPS, that utilization review meeting became about the finances. How much Medicare time do they have? Is the insurance company going to give us more time? What RUGS group are they in? And it got away from being about the patient. So we flipped that on its head and created what we call Pathways meeting. And each week now, those skilled patients are going to be reviewed by your clinical team here and your operations team here. And we're going to put that patient back at the center. We're going to discuss that medical presentation. What's going on currently with the patient, and what do we see as the potential? And we'll go into rehab, and what do we see? What are they doing with rehab? What's their progress, and what is their rehab potential? And then we'll spend the whole backside of that page on what we call the care coordination or the discharge plan for that patient. And the whole goal of this is to identify barriers here at the facility and barriers at home that are going to make that patient transition unsuccessful. So as a team meets each week and they're looking at that clinical data, their job is to really answer two questions. What do we need to do to get this patient home quickly and safely? And what do we need to do to keep this patient at home once they get there? We don't want 40% of the patients we send home bouncing right back to the hospital, or 20% within 30 days. Ultimately, as we move forward in healthcare, we're going to be measured by how successful those patients are at home, so we want to make sure they're staying there. So if we can use this tool, and as a team we can help to identify those barriers each week, we can put those patients in a better position to be successful at home. We'll also make sure we have that patient engagement and that patient activation, where we include the patient and we include the family in their care and try to really bring them back into the fold with their health care. So we have what we call the Your Path meeting, and that meeting should happen within the first 3 to 5 days of that patient being admitted here. And then we're really trying to do the same thing we do with Pathways. Discuss with that patient and family, what do we see medically, what do we expect, where they're at with the rehab progress, and what do we expect with their potential, where we think they'll get to. And then really get into that discharge plan. And the same two questions we ask our teams, we want to ask with that family and patient. What do we need to do to get you home quickly and safely, and what do we need to do to keep you at home when you get there? So we're really trying to identify those barriers and find out what's going to prevent that patient, see what services, what communities they live in, what services those communities offer, and really make sure we're putting together a comprehensive good discharge plan and plan for that patient to be successful. Those are the two things that we'll do internally and sort of externally to make sure we're improving those transitions and ultimately communicating better with the staff, with the patients together as one group. How many are you familiar with Interact? Some yeses, some maybes, some blank stares. How many are you familiar with Stop and Watch? All right, a lot more familiar with Stop and Watch. Good, that's good. Stop and Watch is a tool of the Interact process. Interact was developed a little over 15 years ago out of Florida Atlantic University. It was developed by Dr. Auslander and a group of about 30 skilled nursing facilities in 2 states. It was a CMS pilot project. At that time, they were working on, and still continue to work on, ways to reduce those unnecessary transfers that we see here at a skilled nursing facility back to the hospital, especially within that first 30-day window. Nationally, when they put this program together, it was well over 30% of those patients, or more than 1 out of every 3. Nationally, that's down to about 1 out of every 4, about 24–25%, and coming down. It's coming down because of programs like the Interact and a few others that are out there. Stop and Watch, again, is one of those tools of the Interact process where, again, it takes the entire community to be involved. It really gets everybody involved. You know, as a nurse, when we're passing meds and we're on and off the floors throughout the day, you guys spend as much time, whether you're in housekeeping, dietary, activities, therapy, sometimes with the patients as we do, if not more. You know, as a nurse, you may start your med pass in room 101, and I don't know what your room numbers are here, but you may start in room 101, and it may take you an hour and a half to two plus hours before you get to room 120 when you're doing your med pass every morning. Maybe you as a housekeeper are down there in room 118 every morning, and that's where you start your day with Mrs. Smith, and as you're cleaning your room, you have a nice conversation with her. She has a nice conversation back with you every day, but today something just seems a little off. She either doesn't communicate as much, maybe she's not as jovial, there's just something off. You don't have to clinically, as a housekeeper, activities, therapy, know what that means. But it's your opportunity to grab that Stop and Watch tool, circle, talks or communicates less. Put your name on it, the patient name on it, and the nurse. Get it down there. Nurse will use another tool of that Interact process called an SBAR, or a change of condition, where they're going to do that head-to-toe assessment. And they're going to contact that physician, and that physician's going to understand what that head-to-toe assessment of that SBAR is. And we may have just prevented a major change of condition from happening. Maybe it means monitoring, a little more frequent monitoring for that patient. Maybe it's a med change, a little bit of lab work to find out further what's going on and diagnose what's going on. But that's how, again, everybody can be involved. And that's what Interact's designed to do. It's really a program designed to bring the entire community together working towards those same patient goals. There's other really good tools in there. You guys have your all-staff binders at each one of your nurses' stations. I'd encourage you to look at them. If you're here on nights, weekends, I'm sure we have a fair amount of night shift folks in this morning meeting. You know, if you have families or patients that have questions, there's about 7 or 8 good patient education tools in that binder. They're all written at I think a 5th or 6th grade reading level, so they're very easy to explain and understand to patients and families. But it's good education if you don't have a department manager here or a social worker here or somebody like that to go to to really get them started and get them some information at least in the meantime. It also talks about making sure we talk about advanced directives and really those directions of care for the patient. All too often we just sort of assume that every patient that comes into the building we want to give as much rehab to and their goal is to get home. It's not always the case. You know, as we look at that and we talk with the family about what their goals are, maybe they've been to the hospital 8, 9 times already this year. And they're just tired and that's not their goal anymore. So maybe they want to do not hospitalized work. Maybe they want a DNR order, a full measures. Whatever the case may be, we want to have those discussions. Maybe palliative care or hospice is appropriate for those patients. So we need to find out what those discussions are and make sure we're doing the right thing for those patients and following what their wishes are. That's what really Interact is designed to do. It's designed, again, to really reduce that. Full use of the Interact process, stop and watch, the S-bars, the patient education tools can reduce readmissions by upwards of 35–40% in the facility. So we'll continue to use that here and really at all of our facilities. Any questions on Interact? No? How many of you have turned in a stop and watch here before? Good. All right, a good amount of you. Really the fourth and final critical piece of the program is the discharge planning. If you've been in long-term care any length of time, you've probably seen some major changes over the last probably 3 to 5 years in discharge planning. Years ago, discharge planning in long-term care meant the rehab director was going to let a social worker know probably 2 to 3 days before that patient was ready to go home, and that social worker would pick whatever mom and pop home care company brought them donuts and tchotchkes that week. Didn't have anything to do with the quality of that home care, didn't really have anything to do with even necessarily what were the specific needs of that patient, what were the specialties of that home care. It just had to do with who was on the tip of the tongue. So we really got to change how we're doing things. And SABRE has done that. I think a lot of facilities nationally have started to change, but we're going to continue to evolve in how we discharge plan. Again, the days of us being responsible for just the patient here are long gone. We're going to be responsible for those patients' care up to 30 to 90 days after they leave us. So we've got to make sure we have good partners and we're putting in a good discharge plan. One of the first things we're going to do is engage that patient's family doctor, what we call the primary care physician, or PCP. So the first thing we'll do is somebody here is going to take a postcard out and they're going to get this information over to that family doctor. And it's simply going to read, the clinical team here at Caring Heights is pleased to let you know that Mrs. Smith was admitted to our facility on September 10 following his or her recent hospitalization. This is typically the first time that patient's family doctor ever knew they were, 1, admitted to the hospital, 2, admitted to a skilled nursing facility. These doctors just don't go to the hospitals anymore. You've got pulmonologists, cardiologists, you've got hospitalists at the hospital, internal medicine doctors. The family doctors don't go anymore. So we want to make sure we're bringing them back into the fold and letting them know where they're at. It'll go on to talk a little bit about the PATH program, and it'll say, based on their clinical picture at the time of admission, we estimate the length of stay to be 15 days, 20 days, 25 days, whatever is most appropriate number for that patient we feel at that time. Goes on to tell them that we're going to be contacting them to set up a primary care physician appointment when they leave this facility. And our goal will be to have that appointment set up within 3 to 5 days of that patient leaving here. I told you guys earlier that almost 40% of the patients end up back in the hospital every 90 days. If we can get this patient's doctor involved in their care and get this patient to see this doctor within 5 days of leaving this facility, that number nationally can drop to less than 10%. So it'll make a pretty big difference. If I got rid of everything else in the PATH program, we got rid of Interact, and we did just this one thing, we'd make a pretty good dent moving us from that sick care model to a health care model. So we'll make sure that we're doing that. Second thing we did was we standardized our discharge instructions across the board. It's 1 page front and back. It really gets to sort of the meat and potatoes of what that patient needs, cut all the fluff, and make sure that that patient has it. So we'll go through that with the patient. We'll encourage them to take this to their primary care physician. Hopefully home care gets a copy and sees this as well. But we're also pretty realistic. A lot of times the patients, as we spend the time with them, patients and families may not go through this again. So we'll give them what we call a MyPath home postcard. Again, another sort of business development material, but it's also very good for the patients to have. It comes with a magnet. They can put it on their fridge, and it really pulls out 5 key things we want them to have handy. The first one is that patient's primary care physician. Their phone number, the appointment date that they're supposed to be there. A consulting specialist, their phone number and the appointment date. As length of stays continue to get shorter and shorter on the skilled nursing facility side, you know, a lot of times orthopedic patients come in here and they've got a 30-day follow-up. Well, they may be home day 15, day 10 now. So we want to make sure they know when that orthopedic follow-up is when we get them to that appointment. But maybe more importantly than that, we find out do we have a CHF clinic in the community, a pulmonary clinic, a diabetes teaching clinic, any of those sort of things that we can steer those patients to and get them hooked up with. So again, they continue that education at home and continue to be successful when they get there and are able to stay in their home. We'll put the home care agency on there, the phone number and the date they're supposed to come out, the durable medical equipment company, and lastly their case manager here at Caring Heights. We want them to know they can contact us at any point in time. They've been with us and we can help them navigate that healthcare system. If you guys have done it for yourselves, for your kids, your mom or dad, you guys know you call a hospital to set an appointment up, you get transferred to 3 4 different centers. So we want to help them if they need that help. We'll also make sure as part of that discharge plan that we're calling them and we're not waiting for them to necessarily call us. So 48, 72 hours after they leave here, we'll do a nice clinical discharge planning call with them. And it's not that fluff marketing call, did you like us, were we pretty? It's really, again, about that care coordination piece. So we'll ask them, did you understand your home-going instructions and discharge instructions? If not, let's go through those now. And we'll educate that patient the best we can. If it's hands-on things like wound dressings or whatever the case may be that may require more hands-on assessment and teach-back type techniques, we'll then coordinate that with the home care company so they know what the deficit is that the patient's feeling and that we're seeing. We'll ask them, do you still have transportation to that PCP appointment? As we've been doing this now for the last few years, you know, a lot of times the patients will tell us, well, my son or daughter is going to take me, or something to that effect. And then we do that follow-up call, and then life happens. The son or daughter got called out of town for work, the grandkids are sick, and they don't have transportation. We'll set up transportation no different than if they were still here with us. Because we know how critical that is for those patients to get back to that appointment and have that physician engagement. We'll ask about home care, we'll ask about the DME, make sure that that stuff showed up and that home care showed up, and we'll ultimately track and trend all of this information. We want to, one, make sure they're getting to those PCP appointments, and are we being effective getting them in there within the first 5 days of them leaving here? If not, why? Are we waiting too long to schedule? Or is that the PCP doctors can't get the patients in because they're overbooked? And if that's the case, we need to really just work with that hospital system and work with those physicians on how we can better get our patients in more time. Our home health care and our DME, those providers become critical as we move forward in health care. Again, just picking the mom and pop home care companies because they brought you donuts and tchotchkes are long gone. You know, as I did a quick search when I got here the other day, there's well more than 40 or 50 home care providers in the area. And every one of them will sit across from me, will sit across from Lynn, and tell us how wonderful they are. And they all, I'm sure, have good intentions. I hope they did when they opened their doors. But the reality is they have challenges no different than anybody else in healthcare, whether it's staffing with aides, with nurses, with therapists, whether it's with use of technology. You know, some companies are larger, or some companies put more faith into technology, and we need to find out who's utilizing technology. You know, there's good home care providers out there that have wireless scales, for example, for CHF patients. The patients get on those scales every day. That scale transmits back to where a nurse practitioner or a doctor is looking at that and can adjust their meds on a real easy basis. They've got other companies out there that are using telehealth, where they're putting video monitoring systems in the home, where that patient can get in front of that video monitor, the patient can see the doctor can see the patient, and they can do an assessment right then and there when you're talking about patients in a rural area or anything like that. So we need to find out who those providers are and really pick probably 2 or 3 in the area here that we're going to recommend and that we know are providing good services, and we'll ultimately make sure that they're doing that and that they're focused more on the outcomes of the patients than the quantity of patients that they get. That's really the PATH program in a nutshell. There's a few other things here I'll show you that I think you'll be excited about and you'll be happy to see here. And the first one is a new customer satisfaction survey. Now the facility here does one now. It's 26, 28 questions long. It's all on paper. You guys have probably never seen the results. Have you guys seen any of your survey results? Yeah, probably not, because it's on paper. It's not ultimately very effective other than the administrator to be able to see a few trends. This will be on an iPad. It's 10 questions long. They've started using that this week. It covers all departments. But the day of discharge, day before discharge, somewhere right around there, we'll go in, take that iPod, the patient or family can touch screen those answers. And then you guys are ultimately going to get a good picture of where you guys stand on a month-to-month basis. A couple example questions. Was the staff helpful, courteous, and professional? Did the staff provide quality nursing services? Do you have access to physicians? We'll ask about therapy. We'll ask about dietary and all the departments here. Ultimately, we'll ask them, would they recommend us to others? And each month, then Lynn will make sure that these numbers are posted so you guys can see where you stand. The bonus with this is, and I think the real benefit of this is, it's not what I see as I come in as a regional operator, what Marlene or Jolene or any other regional or Bill or anybody else. It's what your patients see and feel about you. So you guys will get a good picture of what they think and where you guys stand. If you're doing well at something, great. If you're not doing so well at something, you'll be able to recognize that and be able to work towards a plan on how you can improve that. The kicker is you guys will be able to see that. You'll know. So when you're having an in-service or your town hall meetings and you're getting that education or there's somebody's talking to you about that, you'll understand why and where that's coming from. In addition to that, the patients, you'll also get what we call the clinical quality report card. Now this will start in the 4th quarter of this year. But these pull out 7 key quality measures that we want you guys, as a staff, to know where you stand. You guys probably hear about falls, you hear about wounds, you hear about those sort of things, but you don't know where you stand in comparison to your peers, to the other facilities in the state or your national level. So these are 7 key quality measures that we're going to make sure you guys are aware of where you're at. First one here is your 30-day hospital readmission rate. Again, nationally that number is around 24–25%. This is where you guys are at year to date. You've had that's through July, so you've had 151 admissions. 27 of those went back to the hospital for almost an 18% readmission rate. Now while that's lower than the national average, it's above the SABRE benchmark of 15% and right around above the SABRE national average, which SABRE right now in our 64 skilled nursing facilities is running right around 15–16%. So we want to continue to work on that here. And it looks like maybe it was just 2 months here, January and February, that caused that number to be higher. You've been really good since March. June 7%, July 5.3%. So again, we'll continue to work towards that, and hopefully those numbers will continue to drop for you guys. Next 5 I'm going to read off. You guys tell me what you think they have in common. First one is in-house acquired pressure ulcers. Second one, patient falls with injury. Patient acquired nosocomial infections, which is like a pneumonia that develops here at the facility. Urinary tract infections and high antipsychotic medication use. What do you guys think those 5 things have in common? That's right. They're all preventable items. Those 5 things represent the very basic care and services we're charged with doing. Not the extraordinary things I see and you guys see every single day that all these departments and all your departments do. And we do some extraordinary things in long-term care with our patients. But these represent the very basic. Are we turning and repositioning our patients? Are we keeping them clean and dry? Are we hydrating our patients? Do we have good infection control practices to prevent that pneumonia or prevent that urinary tract infection? Are we treating our Alzheimer's and dementia patients well? Are we approaching them well so we're not always having to ask for Ativan or Haldol every time we want to give a bath, shower, or provide AM or HS care? Very basic. Again, as I meet out with hospitals, as Glenna and Jen meets with insurance companies and we talk about partnerships, these are the basic things they want to know, where we're at and how we're doing. Not all those complicated numbers. This is really the start and the end of our conversation. If we look good here, we're probably doing a lot of the other things right. These 5 things are also part of your 5-star rating, which is on Medicare.gov. The problem with the 5-star rating is that data is at a minimum of 9 months old. So what you're looking at online and what our patients and partners are looking at is what happened essentially last year. You guys will see where you're at on a month-to-month basis in current data. So you'll see where you're at versus the state and then versus the national benchmark. Last one on there is short-term average length of stay. And this has really been a newer one over the last probably 2 to 3 years, and it's continuing to be more and more important. In short-term average length of stay, the reason that our hospital partners are looking at that, our insurance companies are looking at that we partner with, and ultimately our patients and families are looking at that is because there's models out there in the industry. There's a geriatric rehab unit model in Akron that this was really developed off of. There's a large conglomerate of healthcare organizations and groups in the Dallas-Fort Worth area and the Minnesota Twin City areas that have shown CMS, that have shown the hospital partners, that if you're putting things together and you're providing that patient education and getting them engaged in their care, if you're providing that staff education and making sure we're working towards competencies and good things for our staff to help increase those outcomes for our patients, if you're putting a good, solid discharge plan and care coordination piece together, that you can shorten length of stays and ultimately those patients are going to have better outcomes. Nationally, that number right now is around 29.8 days. That number is continuously coming down. I think probably in the next year to probably a year and a half, we're going to see that national number for Medicare patients being around 20 to maybe 22 days tops. And it's not just what Medicare wants to see, but it's ultimately what our patients and the communities want to see. That those deductibles and copays went up. You know, patients want to get home. It's costly. And we have some beautiful facilities. You guys got a nice facility here. You got a good quality of nursing staff that I'm seeing by looking at your numbers. But the reality is this isn't home, so those patients want to get there. So our job is to figure out and make sure we're utilizing the tools of the PATH program, for example, to put the patients in the best position to be successful when they go home. And that's really the PATH program in a nutshell. Again, it's really for us as an organization, it's about flipping that switch from that sick care model to a true health care model. Not looking at just heads and beds, but looking at what are the outcomes we're providing here and what are the outcomes for those patients when they go home. That's ultimately how we're going to be successful, and ultimately how our patients are going to do well and be successful, and how we want to be measured. So are there any questions, thoughts, comments? No? All right, well, I appreciate your time. Thank you guys for all you do. Appreciate it. Thank you.
It's gonna get busy.
Maybe you can.